Paresthetica. I'm joined today by Elias Rizk, and we're very fortunate to have Dr. Amgad Hanna with us. Dr. Hanna is a professor of neurosurgery at the University of Wisconsin and really a thought leader in this area. He's contributed much of the field regarding the surgical management of Meralgia Paresthetica, and we're very pleased to have him. So thank you for joining us.
Thank you, Jared and Elias, for the invitation. I appreciate it.
Thank you for joining us.
So for a patient with concern for Meralgia Paresthetica, how do these patients typically present to you, and what are some of the risk factors that you might look for?
In general, it's very common in overweight people. It's reported more in males. That's true, but I see it a lot in females as well. And there is a subset which is iatrogenic. So I see it sometimes after hip surgery, especially anterior approach. Also, we see it in neurosurgical patients after prolonged prone position, whether it be a posterior fossa surgery or more commonly after a very long posterior spinal fusion case.
Exactly. Yeah, I've been seeing that more and more frequently as well. How about in addition to clinical signs, if you're examining them in the office, what are some of the physical exam findings that you would assess for?
I think the key for neurosurgeons is to differentiate a case of Meralgia Paresthetica from an L2 or an L3 radiculopathy. And almost all patients I see with Meralgia Paresthetica, they have a burning type of pain that's very characteristic. And almost all of them have diminished sensation in the anterolateral thigh. Also, of course, because it's a sensory nerve, they don't get any motor deficits. The unique thing about the sensory loss, it tapers towards the iliac crest, contrary to an L2 or an L3 radiculopathy.
Great. And in terms of the differential, I think it's because it's a purely sensory nerve, we're not seeing a lot of the typical motor symptoms that might accompany other problems like L2-3 radiculopathy or femoral neuropathy. How about, do you ever encounter lumbosacral plexus or pelvic pathology that might be contributing to Meralgia Paresthetica or masquerade as it?
I have not, like most cases, like a retroperitoneal hematoma, for example. I see it more involving the femoral nerve rather than the LFCN.
Okay, great. And besides history, let's say for radiculopathy, history of back pain, radiating leg pain, how do you use other supportive tests such as MRI or EMG when working up these patients?
The EMG is not very useful in Meralgia Paresthetica because of the body habitus of those patients. So if they don't get recordings from either side, then it's not helpful. If they get no nerve conduction on the symptomatic side, but they get good nerve conduction on the healthy side, then that would be a diagnostic EMG nerve conduction study, but unfortunately that's rarely the case. I guess the main benefit of an EMG would be to rule out a radiculopathy.
Okay, great. And as another potential test for workup, do you use injections in the perineural injection around the nerve preoperatively to help with decision making?
Yeah, I rely a lot on those to confirm my clinical diagnosis. I rarely order EMG for these, so I usually request an ultrasound-guided injection.
Okay, great.
How long do you think it takes for a patient to show up in your clinic? Like, is this a disease that is missed on a lot of times?
Completely agree. Most people I have seen have been around for a while. Some of them have already had their labrum repaired and sometimes even an ALIF, and they don't get better, and they finally get the right diagnosis.
Question for you, like for the primary care doc and or the surgeon, orthopedic surgeon, neurosurgeon, what are the things that we need to pay attention to be able to pick those up earlier?
So a lot of these we already mentioned, but I can summarize them here. The pattern of pain, the burning, the allodynia, the distribution of the sensory loss tapering towards the iliac crest, the absence of a motor deficit, the reflexes are normal. But sometimes you get overlap, right? Most of the population, they have back pain. So back pain could be a distractor, and you still have to look for Meralgia paresthetica, even if people have back pain. And then in terms of ancillary studies would be an EMG, an ultrasound guided injection. MRI you would do for the lumbar spine if you're still suspecting radiculopathy.
I think you touched on it very nicely. They're very hypersensitive, like even, clothes or any type of, bed sheets can cause a lot of significant symptoms, and that's not typically seen in radiculopathies. So we really need to pay attention and broaden the differential. Not everybody with a back problem will have a radiculopathy of some sort.
Agreed.
All right, so let's say we have a patient who you've diagnosed with Meralgia paresthetica, you've tried non-surgical interventions, patient's been recommended to lose weight, avoid tight belts, they've been on neuropathic pain medicine, maybe even had corticosteroid injections. As we transition a little more towards a surgical discussion, I think this is a nerve very important to be aware of anatomic variants, different origins of the nerve. Can you discuss a little bit about some of the typical variants or the variants that you see in practice?
Yeah, the variation is more than the standard anatomy for this nerve. It can be anywhere from 6 centimeters medial to the anterior superior iliac spine, that we could just call ASIS, to 6 centimeters posterior to the bone. So very variable in its course. It could originate directly from the lumbar plexus or could come from the femoral nerve or even the ilioinguinal nerve. We had a case report coming from there. And it could be a duplicate nerve. It could run in a groove over the area crest. Is some of the dissections we had. Yeah, this is a case where it was originating from the ilioinguinal nerve on the left side and the right side appropriately, so arising from the femoral nerve. This could be seen as well.
And just to complicate things even more for surgery, I know you've done a lot of work showing the anatomic, basically fascial canal that the nerve travels through. And we have a diagram from one of your studies here showing the prior understanding and a more updated version. Can you discuss a little bit how during surgery, making an incision, you can really be thrown off depending on if you're accessing, let's say, where these red arrows here are versus a green arrow?
Yeah, so the left-sided picture here on the screen is showing the older concept that there is just a fascia over the sartorius. If you open it, you will find the nerve. And that would have been true that if there wasn't a complete canal surrounding the nerve. The real anatomy is shown in the diagram on the right side, where there is a second layer deep to the nerve, and hence a 360 canal surrounding the nerve, which means if you don't open just on top of the nerve exactly, then you will be lost deeper than that deeper fascial layer. So you would be in a plane deeper than the nerve and that fascia, and you won't be able to see it.
Yeah,
And
if you see muscle that you're way past where you need to be, right? And I think my initial cases, I learned to look for that tunnel because otherwise you'll be lost and trying to figure out where it is, and it can be very frustrating. And that nerve is not running with a vessel of some sort that you can localize other than just anatomically.
how have
No,
you
there's usually not a vessel within that canal.
Yeah, so what I'm saying is you cannot follow a vessel and say, oh, this is where it should be. So it's on its own, and if you get lost, it's kind of hard to localize it appropriately. So it can get really frustrating if you don't know the anatomy.
Yeah, and if you start scoring that fascial out, it's going to look like nerve, especially
100%.
if you have a recurrent case or after a hip replacement or something, everything will look like nerve.
100%. Yeah.
To make it a little bit easier, I know you've incorporated ultrasound. Can you discuss how ultrasound, how you use that in your practice for localization purposes?
Yeah, in my institution, it's it's hard to bring ultrasound intraoperatively. So we have used preoperative ultrasound localization, where you can get a really experienced musculoskeletal radiologist to find the nerve, and then they would localize it. Whatever technique you want to use, we've used wire for a very long time, and then more recently there is a magic clip that's placed under the nerve that you can navigate intraoperatively. So we have used preoperative ultrasound localization. They put a marker, and then intraop you can just follow the marker. Or if you have good access to intraoperative ultrasound, if you can read your own ultrasound, or if you can bring a radiologist in the room to help you out with the reading, then you could save time and just do it intraoperatively before you make the skin cut.
Yeah, so a lot of great options here. In my practice, we have a pain management physician who's also an anesthesiologist and very facile with ultrasounds. So he's able to come into the room, and it's really significantly decreased the amount of time for surgery. Initially, we tried an A-line wire, but I found that as you dissect down, that wire can sometimes move. I recall in one of your papers using a special type of needle, a Homer Wright needle. Is that something
Yeah,
that
Homer needle. So most of the technology we have used in my institution is just developed from breast biopsies. So if you ask the people who do the breast biopsies over there, you will find better wires and better things to put in there.
Yeah, yeah, absolutely. All right, so two great options depending on your institutional resources. So after this, we can turn now to the surgery itself, and I know there's a lot of different procedures out there, ranging from an external neurolysis to a transposition, and in select cases, sectioning the nerve. Can you discuss a little bit about your surgical approach?
Sure. So a little bit of history of the treatment of this was Meralgia paresthetica. It's entrapment of the LFC and the lateral femorocutaneous nerve in the region of the inguinal ligament. The problem was traditional simple decompression. It doesn't address the layer posterior to the nerve, which could be tethering to the nerve. And it also does not address the nerve riding over the bone, the ASIS, which is actually fairly common in Meralgia paresthetica patients. So when simple decompression didn't work very well, people resorted to neurectomies. And the problem with neurectomy that you have a permanent sensory loss in that anterolateral thigh, and you could get deafferentation pain, and you can get neuroma formation. So the technique we developed in my institution here is a transposition, and that's based on understanding the anatomy that you showed in your earlier slides, that there is a canal 360 degrees surrounding the nerve. So you really want to release the fascia superficial to the nerve, and then the fascia deep to the nerve. And if you do enough mobilization distally and then proximally, you snip that inguinal ligament and a little bit of the fascia iliaca, you will have enough mobilization to drop that nerve away from the bone and then in a softer muscular bed. And we've had very good results with that. And we resort to neurectomy if really this procedure fails, or after iatrogenic injury, if there is any intrinsic damage to the nerve. But our results with the transposition have been very good.
See. And just out of curiosity, when you section the inguinal ligament, are you sectioning a portion of it, or do you cut through the whole ligament?
You cut through the whole thickness, but you have to be very careful because there is the ilioinguinal nerve there. I had one patient complaining of numbness in the ilioinguinal distribution. Thank God it was not painful and it recovered over time, but you have to be really careful about the ilioinguinal nerve there. You don't want to create another problem. And also there are some circumflex vessels that live in the inguinal ligament. So you have to displace those as you're making your cut.
See. And other nerves like the ulnar nerve, when we transpose, sometimes some surgeons will create a fascial sling to keep it in its new position. Any concerns about that nerve ever going back into its original position, or because it's descending from the bone, it's really much less common?
Actually, when we started doing this technique, we were reattaching the inguinal ligament to the muscle bed. But if a patient comes back with some residual pain, it made me nervous if the stitch is still constricting the nerve. So we stopped doing the stitch, and the nerve is so relaxed in the new bed, and it's not going to jump back in the previous position. And we have actually analyzed this series. This is pending acceptance and publication. And there was no significant difference whether you put a stitch in or not. There was a trend toward actually better outcome without the stitch, but nothing was significant.
Great, great. How about after surgery? Any restrictions that you counsel patients about?
I just have them take it easy because it's an area that's hard to take care of. Like initially, I was closing those subcuticular with absorbable suture, and then I switched to nylon because of wound breakdown and some wound infections as well. So we resorted to nylon suture, and just have them take it easy after the surgery. Encourage them to walk, of course, so they don't get clots in their legs, but nothing strenuous, at least for 3 weeks until we take the stitches out.
Okay, great. That's a good pearl about nylons. I've also, it's a tough spot, I think, where if you're in the inguinal crease or even crossing that, but if nylons help, that's something to think about. All right, great. And we talked a little bit about if you have a patient with persistent symptoms, would that be someone you would think about if they've had the transposition and still symptomatic and a high suspicion for Meralgia paresthetica, would you go to sectioning at that point?
Very good question. I would give them another round of injections and see if the injection helps and how long it's going to help for. Sometimes the hydrodissection with the injection would just help with some residual scarring or any pinching around the nerve in that area. And if that doesn't last long, I would consider an neurectomy in that case. You could always consider neuromodulation, DRG stimulation, or spinal cord stimulation.
Okay, great, great. Dr. Rizk, any other questions you'd want to ask or topics?
I had a couple of questions, if you don't mind, Dr. Hanna. When you diagnose with the injections, what percentage of your patient cohort get a long-term cure from just the injection without needing to go to the next stage of doing something surgical?
I can't recall a patient who just got better with injection and never needed surgery afterwards. It usually buys them time, or if someone is undecided about surgery. I think the longest I have had is people writing it off for a couple of years, but they end up coming back for surgery.
I ask this because what you read is opposite in the literature. Like all my practice, all the injections really never, achieve long-term control, and you really have to do something as a next step. I'm glad that you're seeing the same stuff, and I'm sure Jared is also potentially seeing the same observation. The second question I had, when you get the diagnosis and you're trying to, strategize for surgery, do you do any type of MRIs to make sure there's no other pathology anywhere else, or to look at the anatomical relationship of the nerve itself, or do you select those to specific cases?
I think in general, for us nerve surgeons, small superficial nerves are better visualized by ultrasound. Deeper and larger nerves are better seen on MRI or MR neurogram. So LFCN, I think you see it a lot better, even as you showed the ultrasound pictures earlier. This is a picture you will not get with an MRI.
I was more so focusing on trying to rule out any intra-abdominal pathology creating this type of symptom. Nowadays we're trying to get more imaging for ulnar nerve decompressions or preoperative imaging for peroneal nerve decompressions with ultrasounds and MRIs. Just wondering what's your practice as far as, catching LFCN, but it wasn't truly a compression, was something more intra-abdominal. Is it a rare situation? Because I've never really seen a patient present with LFCN typical symptoms and have some form of pathology in the abdomen.
Yeah, same here. Unless you have somebody with schwannomatosis or you have a very high suspicion of a nerve tumor, Otherwise, I would just get the ultrasound.
And for the last surgical question I had for the learners, people, the beginners trying to foray into this, what are the pearls that you would have to, stay away from femoral nerve injuries? I'm sure you've seen patients come in with LFCN typical symptoms, and they had, incorrect exposure somewhere else. So what would you tell, the young person, the new surgeons, your pearls on how to prevent some form of devastating injury?
Learn the anatomy. The cadaver is the best teacher. Go to as many courses as you can. If you're doing a surgery that you're not familiar with, just go to the lab and look at it in the cadaver. Of course, this nerve specifically has a lot of variance in the anatomy, but if you want to refresh your anatomy on the femoral nerve and the femoral vessels to avoid injuring them, the best teacher is the cadaver. And
100%.
second would be atlases or videos. There's almost online videos for everything now, so you can brush up on your anatomy that way as well.
And it's important not to get frustrated, like you said, and having the tunnel and knowing where it is. If you're losing that tunnel, you can foray somewhere else and veer more immediately. So, like you said, spend time in the cadaver lab, do it in the cadaver, and learn as much as possible and be prepared, and use adjunct um, imaging like you do in your practice to localize the nerve better and not get yourself into trouble.
Yeah, and don't hesitate to call for help. Like I have been in cases where the wire was placed in the wrong place and I had to call back for ultrasound intraoperative, or if you have a senior partner like Dr. Rizk, for example, someone could call you, come help me find the nerve, or if you have a senior partner, definitely make use of that.
Yeah, I've called Dr. Kim Harbaugh, who was my mentor on my first LFCN, just to have her around and make sure I'm doing the correct thing. So, like you said, be humble and make sure you do the best outcome for the patient. So it's all these are tried and tested um, suggestions or recommendations that I would tell anybody that if I was asked the same question.
Just to add some other comments to what was discussed, I think Dr. Rizk, for your question about injections, usually I counsel patients that it's really more diagnostic, that even if they get a short relief, that's very useful information, not to expect necessarily long-term improvement. I think it's interesting that I think the classic teaching is there could be lumbopelvic pathology, but it sounds like maybe MRI is not a great use of resources unless there's a high clinical suspicion. But something we could maybe revisit. And for the last point about things to help, I've definitely asked my pain management anesthesiologist to come back and do ultrasound intraoperatively, which was very helpful. So, all right, well, I think that's a great discussion.
One last question, Dr. Hanna. How long do you tell your patients before you can see an actual improvement after the surgery? What is the expectations that you lay ahead so they're not disappointed as far as their outcome?
I tell them everybody is different. Like I have had patients who felt relief the day of surgery, and in some people, depending on how long they have had it for, especially for the numbness and the sensory loss, that takes very long time to come back. But the pain, if we have the right diagnosis, it tends to recover faster than the sensory loss.
Thank you.
All right, well, maybe just as we conclude, we could switch gears a little bit. Dr. Hanna, it'd be great if you were comfortable sharing with us the reason that you went into peripheral nerve surgery.
Well, I went into neurosurgery wanting to do skull-based tumors and clip aneurysms, probably like most of us. But throughout residency, I actually didn't get much exposure to nerves in my training program. But I went to almost every single cadaver course with Dr. Klein through the CNS. And I just fell in love with it, and with great mentors that were teaching the course, Dr. Klein and a whole line of people underneath him. And Dr. Klein also came visiting professor when I was in Philadelphia. I saw him twice over there, once at Jefferson and once at UPenn. So I was really lucky in that type of exposure. And I just fell in love with the anatomy. And first, I wanted to do both spine and nerves, but really throughout my practice, I just fell in love with nerves in terms of research, the anatomy, the prognosis, the beauty of the surgery. And I think if you bring all your neurosurgical skills that you learn in the brain and the spinal cord, you bring that into the nerves, we have a lot to offer that is not offered by other people who do nerve surgery from other backgrounds.
Very true. Very true. How about, I know you've done so much work with cadavers, both for learning purposes, research purposes. Any advice for a young faculty person maybe trying to start a cadaver lab, if you combine with other subspecialties, or how to raise funds for something like that?
It's very institution dependent. And even in the same institution, depends on the leadership of the body donor program. Access could be really easy or really hard depending on what situation you're in. So I would say read the room and study what your institution can offer. And if you can have access locally, that would be the cheapest way to go. Otherwise, you would have to buy the cadavers. And if you have to, then you would have to resort to industry support, of course, to be able to afford it and keep it either free. We always do the course locally free for our residents and the plastic surgery residents. Or if you have to charge a fee, then it should be a small fee so that people are not discouraged from coming to the courses.
I think the best place for me that I was able to access cadavers is working with the anatomical pathology med students during their anatomy courses, and being there as a faculty teacher, I learned more than actually taught sometimes. So being there, doing the cadaver dissections, you familiarize yourself more. And when you're at this stage, you appreciate the surgical approach more than what you want to see in Gray's dissection manuals or dissectors. So you have a different, mentality when you're prepping for your dissections or doing your dissections. So that's where most of my exposure was. And this is where I was able to utilize those cadavers and then teach the residents or say, this is a pain course. Can we take the limb and do the dissection after you're done? So there's lots of opportunities to maximize those cadavers.
Yeah, definitely the cadaver is the best teacher. So as much time as you can spend, please do.
All right, well, great. Thank you very much for the advice and all the pearls. We appreciate you joining. Thank you.
Thank you for the opportunity.
Thank you.